Hello, am I audible?
Yes, you are.
Yeah, can I start, ma'am?
Yeah, sure.
Yeah. Yeah, good evening, all. Welcome to the 11th webinar of Infectious Disease Basic Module. And myself, Dr. Satya, working as a clinical pharmacist and ID form member of FCPI. And yeah, before going to the session, I just want to give a small kind of instructions to the participants, our audience. The thing is, if you have any kind of doubts or queries, you can just ping or you can drop a message at comment section after the session. And also, if you have any kind of feedback and all the things, you can submit at the end of the session, and that will be available below the comment section. Yeah, third thing related to certification. After submission of feedback, you will be getting certification to your respective mails within 10 days. Hello. Yeah, sorry. Yeah, and fourth thing related to this module slides and the material that you are, if you are willing to take, you can log in directly to the FCPI mod website and you can get it. And finally, if you have any kind of queries or any kind of, you are facing any kind of resistance, you can just ping to the FCPI official mail and those will be definitely sorted out. Yeah. Before going into the session, I just want to also add a small kind of info regarding upcoming modules. This is related to CP module. First thing, CP conclave that is held at Kochi, which is to be held at Kochi on 15th and 16th November 2023. And it is organized by Amrita School of Pharmacy and in collaboration with FCPI. And the main motto of this conclave is engaging students in infectious disease and antimicrobial stewardship. And next one, second CP summit, that is which is to be held at Pune, organized by Indian Pharmaceutical Association of Students Forum and in collaboration with FCPI. And that is held on 25th and 26th of November. And the theme of this summit is empowering students to excel in clinical pharmacy career. And third one, which is most awaited, second ID Congress 2024, that is to be held on 19th to 21st of January. So everyone, it is a a kind of gesture to join all the expertise, and you can learn from the mentors all over the mentors who can guide you, who are excelled in this kind of field. And today's session is related to today's session is related to PKPD parameters of antimicrobials part 2. And also the speaker is Dr. Saidulu Ganta Formd. Dr. Saidulu Ganta has a major certifications of SIDP, AMSP certification and SPH pain management certification. Not only this, he is also part of a major ICMR project, and also he is a major part of antifungal stewardship under GCIDP. And also his area of interest are PKPD parameters of antibiotics, sepsis management, and antibiotic lock therapy, followed by biofilm infections related things. And without any delay, I would hand over the session to Dr. Saidulu Ganta. So the session is yours, sir.
Thank you, Satya, for introduction. I welcome you all the part 2 of antibiotic PKPD. So I'm discussing about the pharmacodynamics in this lecture. In the previous lecture, we are discussing the pharmacokinetics of the antibiotics. I don't have any disclosure information, and the learning objectives the same we discussed earlier. They explain the principles that influence the PKPD in critical ill patient, and describe the rational distinct regimens of antibiotic in critical ill patients. Yeah. So what is the basic definition of pharmacodynamics? The relationship between the drug concentration at the site of action and the resulting effect, including the time course and intensity of therapeutic and adverse effects. So this is the basic definition of pharmacodynamics. So we have a multiple pharmacodynamic properties we can divide into 3, especially antibiotic pharmacodynamics. That is fraction of time of the particular antibiotic concentration above the minimum inhibitory concentration, and the fraction of area under the curve from 0 to 24 hours divided by the MIC, and that Cmax divided by the MIC. So these are the 3 pharmacodynamic parameters used in the antibiotic pharmacodynamics. So the real-time definition of pharmacodynamics in the clinical settings, we call it as if you take x-axis and y-axis, if you build a AUC, and by using that x and y-axis, basically it is the shape of concentration, time profile curve makes a difference. So if you see here, at the 0 time, at 0 concentration, 0 time, if you give any drug, and whether it is a IV bolus or IV infusion, if you suppose if you give IV bolus, that can reach the maximum level, that is called the Cmax. Okay, so this is the drug available in that systemic circulation or in the blood. So this is called the Cmax. So when the time passes, the drug is distributed, metabolized, excreted. So the Cmax gone down, it is a parabolic. So after some time, that reaches the that excreted from the body reaches the 0. So this area called is the AUC. So when coming to the antibiotics, you can always remember your drug levels always should be the MIC of the particular organism. Both are in concentrations only. The MIC is minimum inhibitory concentration, the drug concentration, it should be above the MIC that particular time. That is called T by T greater than MIC. And if your Cmax should be above the MIC, like 10 to 20 times of the MIC, that is called Cmax by MIC or peak by MIC. Then what is the lowest level? It is called the C minimum. That sometimes it should be C minimum also should be above the MIC. So this will able to help kill the organism properly. Yeah. So in antibiotic pharmacodynamics, we divide into the time dependent and concentration dependent. The time dependent means not only is the time dependent, there is some antibiotic concentration also is there that should be maintained above the MIC. So that is called the free drug concentration, not a bounded drug concentration. The free drug concentration always should above the MIC at the for specific bug at the specific infection site. You are not always see in the blood. If the patient have a lung infection, so your antibiotic concentration, the lung infection should always above the MIC of the that infection site. So you always shoot the target, not always the systemic circulation. So this is the new things in the antibiotic pharmacodynamics. And the second one is the prolonged infusion, optimize the antibiotic exposure and the bacterial killing. Because it is called as a time dependent, because the antibiotic killing activity depends on the time, means infusion time. So the time, it contains the time. So how much time you infuse, that will decide your antibiotic killing. That's why we call these antibiotic as the time dependent antibiotics. So usually if you give infusion, that infusion makes your antibiotic concentration above the MIC, that we require around the 4 times of the MIC. So that we can achieve with prolonged infusion or extended infusion. So this prolonged and extended infusion, they are able to kill the organism properly, and they can prevent the resistance also. So that's why in the time dependent antibiotics, we are giving frequent dosing, either TID dosing or every 8th hourly, every 6th hourly, or continuous. These are the time dependent practices we are practicing. And the reason is these antibiotics have a particular short time of life. So they can excrete as soon as possible in the body. So you have to maintain the drug concentration. So your infusion time is always more than the drug of life. Basically, beta-lactam antibiotics half life is 1 hour, but your infusion should be always more than the 1 hour, 3 hours or 4 hours. So this is about the time dependent. If you come into the concentration dependent, so this antibiotic killing depends on the maximum higher concentration of the antibiotic. So that is Cmax. So this Cmax, your Cmax should be above the MIC of the specific bug at the infection site. And for these particular antibiotics, the concentration dependent antibiotics, you don't require to give the prolonged infusion. It's not required because those are not time dependent. because these are the time independent. You can give as a IV bolus, not required to give 3 to 4 hours infusion. The requirement thing is you have to maintain the highest concentration in the systemic circulation or at the targeted site. That is the required pharmacodynamic endpoint. So here higher concentration prevent the resistant. In the time dependent, prolonged infusions prevent the resistant. Here higher concentration will prevent the resistant. So that because these higher concentration prevent the resistant, that's why called as a concentration dependent. So these are usually only one day dose, OD dosing or twice daily dosing. And the reason these have a long half-life and they have a post-antibiotic effect also. These concentration dependent antibiotics. It's not necessary to give like very frequent because they have a long half-life as well as they have a post-antibiotic effect. These concentration dependent. So if you see the first pharmacodynamic parameter, fraction of time above the MIC, in a non-critically dull patient, you can maintain the antibiotic concentration levels above the minimum individual concentration 40 to 50% of the antibiotic dosing interval. I have an example we can discuss in detail. And 100% means 100% of the dosing interval. In that particular 100% dosing interval, you have to maintain the antibiotic concentration above the MIC. So for this, if the patient is critically ill or immunocompromised or neutropenic patient, in these patients, your antibiotic concentration above the MIC 100% of the dosing interval. Either the dosing interval may be 8 hours or 6 hours or 4 hours or 12 hours, whatever it is. If it is 8 hours, you have to maintain that antibiotic concentration above 8 hours above the MIC. So it gives the greater clinical cure. And if you don't maintain that your particular antibiotic concentration is less than the 50%. If it is dosing interval is 8 hours, but if your drug is there only 2 hours above the MIC, so that is not actually good. So that is basically increase the risk. It increases negative clinical outcome that increase the mortality. And that higher dosing has a minimal effects on extent of bacterial killing. In these time dependent antibiotics, even though there is no benefit of giving high dose, rather than you have to give very frequent dosing. There is no benefit of giving higher dose. Like you cannot always sit with the higher doses. So rather than giving high doses, you have to give very frequent dosing, like every 4th hourly, 6th hourly, or every 8th hourly. So that is the very important. And either you can infuse the antibiotic give the antibiotic very frequently, or give the antibiotic prolonged infusion or extended infusion. It can help you in the clinical cure. It can decrease the mortality and 30 days survival rate. So except the prolonged infusion, we have some data for continuous infusion. We have a mixed results. There is only improvement in the clinical cure. There is no particular effect on the mortality compared to the prolonged infusions. And for example, beta lactams, if you maintain that drug level above the MIC for 100% dosing interval, so you can expect the drug concentration 4 to 8 times of the MIC. Suppose if your MIC is like 1, so your drug concentration 4 to 8 times means your drug concentration should be around 8. So you have to maintain, and especially in the immunocompromised populations. So no benefit of higher drug concentration above the MIC. So here the Cmax doesn't matter. The only have to maintain the drug level above the MIC. If you maintain the drug level below the MIC at the site of infection, that can evenly resume the bacterial regrowth, and so that adversely affect on the clinical outcomes. So always remember, for beta-lactam antibiotics or the time-dependent antibiotic, infusion time matters. So how much time you infuse that matter. You have to infuse the longer infusion time, like more than 3 hours, 4 hours, 5 hours, 6 hours, like that. Not to give like a bolus doses. And this time-dependent concept works for the gram-negative infections only, because when you are treating the gram-negative infections by using the beta-lactam antibiotics, these beta-lactam antibiotics, they don't have a post-antibiotic effect when you're treating the gram-negative infections. So that's why you need to maintain the sufficient levels most of the dosing interval. And if you see the example, I'll keep one example here. If you the meropenem regular MIC 0.25 mcg per ml, that is that particular MIC of meropenem. If you give the antibiotic of meropenem loading dose, like bolus dosing, the maximum Cmax is the 49 to 54.7. But the meropenem antibiotic activity not depend on the Cmax. It depends on the how much time you infuse the drug. So meropenem C minimum is the 6.27 that we can consider as the steady state concentration. That is around the 8 to 12 mcg per ml. So your target should be you have to maintain this 8 to 12 mcg always above the MIC in that particular dosing interval. If you see the meropenem dosing 1 gram TID means that is a Q 8 hourly dosing. The dosing interval is the 8 hourly. So here is if you take 40% dosing interval of the 8 hours, that means 3.2 hours. 75% 6 hours. 100% dosing interval means 8 hours. So does mean like in this 100% dosing interval, your drug levels or your meropenem levels at least above the MIC. That means you have to maintain your levels at least 8 to 12 mcg per hour up to 8 hours. That can maintain by if you give the drug around 3 hours of infusion. I think you can understand. Like see, if you see here, the prolonged infusion helps to maintain the meropenem level above the MIC for at least 3 to 6 hours. If you give the continuous infusion, that can maintain your drug levels around what we required 8 to 12 mcg per ml at least 8 hours. That is called the 100% dosing interval. Especially if you are giving in the patient on CRRT, ERT, you can prefer continuous infusion. So there is a new concept in the meropenem like pharmacodynamic parameter. Apart from the time dependent, now we are considering the C by MIC, that is the 4 to 6. For the deep-seated infections, any lower respiratory tract infections, Pseudomonas, when you are treating these particular infections, apart from that, giving the prolonged or continuous infusion, you can calculate if you have a MIC, then so you can calculate your C minimum. Like you can multiply MIC with 4 to 6. For suppose in this case, 0.25 into 6 around. So 1.5. Your C minimum value is, if you maintain the C minimum above the 1.5, we can happily treat with the deep-seated infections, LRTA, Pseudomonas. So this is the new pharmacodynamic parameter in meropenem. And the second parameter, Cmax by MIC. Higher peak concentration optimize the bactericidal activity, followed by the lower troughs that minimize the toxicity. So in this, if you see the aminoglycosides, if you take aminoglycosides, the peak will decide the antibiotic activity. Then the lower troughs are the trough values for the toxic effects. So measure of the Cmax in relation to the organism of the MIC. So higher doses with the once daily frequency result in the targeted Cmax by MIC values. And if you see that, for example, fluoroquinolones for in Pseudomonas infections, we consider as a Cmax by MIC for fluoroquinolones. And AIC by MIC, this is like a mixture of time dependent and concentration dependent. It can include the both. You have to give like at least certain like prolonged infusion, like at least 2-3 hours infusion of drug, as well as you have to eat with the higher doses. It is a mixture of time dependent, concentration dependent. That's why we call it as a AUC by MIC. So we can simultaneously adjust the dose, and we can simultaneously increase the frequency, or you can increase the prolonged infusion. So this is the example is the aminoglycosides PD target in the enterococal endocarditis infections. So if you see the examples, antibiotics comes under the time dependent: penicillin, cephalosporins, carbapenems, natural macrolides, clindamycin, linezolid. It comes under the oxide agents. Concentration dependent: aminoglycoside and fluoroquinolones, and phosphomycin, colistin, metronidazole, and daptomycin. So that's why daptomycin always have a OD dosing, and metronidazole, it should be like actually OD dosing, but still we are practicing TID dosing. There is no benefit of TID dosing. You can hit with the 1500 mg OD dosing because it's a concentration dependent. Though there is no need to give TID dosing of metronidazole because it is concentration dependent. Aminoglycosides we always hit with the like OD dosing. Fluoroquinolones also OD or BD dosing. Phosphomycin, like the recent study shows that it is like time dependent as well as a concentration dependent. When you are treating the MDR infections, phosphomycin pharmacodynamic parameter comes like a time dependent. That's why 4 gram you can give as a Q6 hourly, Q8 hourly, and you all know the time dependent. We are giving that all penicillin, cephalosporins, and TID and QID dosings. And linezolid is a BID dosing, but in the critical ill patient, you can infuse the linezolid around 3 to 4 hours. That's very important. Clindamycin is a TID dosing. That's because time dependent. And yeah, so if you see that PKPD index, this is the like T by MSC, Cmax by MSC, we already discussed. So the what is the objective here? When you have a time-dependent antibiotics, you have to maximize the duration of exposure by increasing the infusion time. For concentration dependent, you can maximize the concentration by giving the maximum highest doses. Give it the highest maximum dose range with OD dosing. And in the concentration plus time dependent, you can give the maximum dose with the maximum exposure. And what is the measures? Like in the time dependent, frequent administration or prolonged dosing. In the concentration dependent, infrequent dosing. Either you can give only once daily dosing with high doses. And in concentration dependent, time dependence, you can give the high doses with the prolonged infusion concept. And if you see the PKPD index for amikacin, for if you know the Cmax by MIC 8 to 10, that means if you know the MIC, just you can calculate your Cmax by multiply MIC with 8 to 10, that is your Cmax of amikacin. And like gentamicin and tobramycin also. And carbapenems 50 to 100% of the dosing interval of the above the MIC. These are the linezolid AUC by MIC, like vancomycin AUC by MIC, and ticoplanin C minimum, it should be like more than 10 mg per liter. So these are the different PKPD targets of the different antibiotics. And special patient populations, like critical ill patient with a sepsis and septic shock, severe trauma and burn injury, major surgery, febrile neutropenia, cystic fibrosis, organ dysfunction, patient underwent the special like CRRT, ECMO, obesity, pregnancy. So these set of patients require like PKPD dosing approaches, especially. And what is the concept of the post-antibiotic? So persistent suppression of bacterial growth after a brief exposure of the bacteria to an antibacterial agent may occur even in the absence of the host defenses. So this is called the post-antibiotic effect. If you see the gram-negative organisms, beta-lactams hardly have a 0 to 1 hour for susceptible organisms. That's why when you take the gram-negative infections, we are giving the beta-lactam antibiotics multiple daily doses because they don't have any post-antibiotic effect. And carbapenems post-antibiotic effect, they are 2 to 4 hours if you give a prolonged infusion against Enterobacteriaceae Pseudomonas aeruginosa. So that's why like carbapenems have a like the reasons why in the beta-lactams, why the carbapenems are the preferred compared to the penicillins and cephalosporins, they have a post-antibiotic effect if you give the prolonged infusions after your drug levels fall below the MIC also. And polymyxins have 1 hour of post-antibiotic effect for gram-negative infections. In the gram-positive infections, beta-lactams hardly less than 2 hours, but that for only susceptible organisms. And vancomycin 5 hours for the MRSA, and aminoglycosides at least 1.2 to 12.8 hours. And this is one of the reason we are using the gentamicin infecto endocarditis, but still using gentamicin infecto endocarditis for the gram-positive infection, that is like outdated concept. And fluoroquinolones 1.9 to 7.5 hours. That's why moxifloxacin, when you're using that gram-positive infections, moxifloxacin for so the body dosing, the reason is like it have a longer post-antibiotic. That is the reason moxiflox have a like body dosing. And the same reason like daptomycin have a 6 hours of post-antibiotic. So this is also one of the reason we can give the daptomycin OD dosing for MRSA and enterofacialis infections. And current practice of antibiotics in ICU, we generally using the conventional dosing that is recommended by the manufacturers, both in empirical setting as well as the directed therapy. And we are considering only the organ dysfunction and culture sensitivity of the organism, but we are forgetting about the patient and the drug PKPD in the critical ill patient. Maintaining the same treatment dose over the treatment duration without considering the PKPD changes. So this is we are practicing. We are ignoring the PKPD changes in critical ill patient. So what are the other sides of the current PKPD practices for concentration dependent antibiotics? In the presence of any PK changes, especially volume of distribution, if the concentration dependent antibiotics, they reach the higher peaks very toxic peak, there is the higher peak level that can cause the toxic level, and the time between the doses may not enough to achieve the adequate rough concentrations. So this is the problem for concentration dependent antibiotics if there is any changes in the volume of distribution. So this already we in detail discussed in the part 1. So for time dependent antibiotics, sometimes in critical ill patient, there is changes in the clearance, like because of altered renal clearance, some ARC concept, whatever the reason, or hyperdynamic sepsis. Sometimes the clearance of the antibiotic is increased. That's so many physiological reasons. So sometimes where antibiotic concentration fall below the C by minimum. So we already discussed the C minimum values we can consider for the beta-lactam as a steady state concentration. So it should be above the CSS or C min. But because of some reasons, the antibiotic concentration fall below the C minimum, that can call this a suboptimal level. So that adversely affect it can unable to kill the organism properly. This is the one of the reason. And sometimes your antibiotic concentration like more than like more than like couple of times of the your C minimum level. Sometimes that can lead to the toxic level, especially beta-lactam antibiotics in the renal dysfunction. The recent studies say that like higher peak levels of beta-lactam can trigger neurotoxicity, especially organ dysfunction patients. So how to manage these things? Like what is the PKPD dosing approaches? And how you dose the antibiotic PKPD dosing rather than the standard dosing. So what factors you can consider when you're dosing that antibiotic in ICU patients? So either you need the measured concentration. This is not always possible in our settings, and we don't have that kind of setting in every hospital. And either you can consider the other clinical covariate like TF and rate of elimination constant, elimination rate constant, volume of distribution, and clearance. So because these things are altered in critical ill patient, so we have, based on considering these clinical covariates, like we can change our antibiotic dosing practices. So by using the nomograms and antibiotic dosing frequency based on the graph, especially we have nomograms for that aminoglycosides and meropenem for in critical ill patient. And either we can use the population PKPD. So this population PKPD, they're like studying the different set of like patients, like patients with septic shock with CRRT, patient with septic shock without CRRT, patient with septic shock with heart failure, patient with heart failure with CLD. So they are like in the research they are studying the different clinical conditions, and they calculate the different clinical covariates like. So see, the TF is very different with the patient with a normal healthy adult in the CKD patient. Like that, they are calculating the different clinical covariates like TF, volume of distribution, clearance, and rate of elimination constant. By using these population PKPD parameters, we can apply this PKPD data to our patient, and we can predict the dosing. We can predict the proper dosing rather than the regular standard dosing that anyway is not useful in the ICU patients. And comparing with the predefined target. So if you want to achieve like if there is an antibiotic, you want to achieve like 10 mg per liter. So you can use them PKPD calculations. You can predict with your dosing. If you give like 1 gram per day, so with that 1 gram per day dosing, either you can able to achieve the 10 mg per liter or not. So this is the one of the practice. And this is the Bayesian forecasting. There they are using the computer software. There are like they have thousands of population PKPD models in that particular software. If you enter the patient clinical covariates like TF, KE, volume of distribution, clearance, and the dosing, body weight, creatinine clearance, everything, this Bayesian forecast software automatically give the whatever the required dosing for your patient. It's like an individualized dosing concept. So I'll take you 2-3 examples how to calculate that PKPD dosing in the regular, how are we calculating in my practice. So like there is one example, like calculate the initial dose regimen, include dosing interval and dose for X drug for the treatment of an infection. There is an antibiotic that used to treat the infection. So for that, you need to calculate the dosing interval and the dose. So as a clinical pharmacist, how to you can calculate. So for this patient, we don't know any clinical covariates like rate of elimination constant and the volume of distribution. So these two, like rate of elimination constant, volume of distribution, we'll get it from that from the literature with the same set of patients. Those are published in the literature. We can use the same set of patients. We'll get these values from the literature, and the Cmax and Cminimum also we are getting from the literature. If our patient, we can find the same set of same similar presentation like our patient in the literature. You can get that these values from the literature like CSS and Cminimum and C rate of elimination constant, volume of distribution. So for this patient, we can use the IV bolus pharmacokinetic equation. So see, there are the different infusion practices we are practicing in regular daily. For IV bolus, we have a different dosing concept. This is the tau, it is called the dosing interval. For dosing interval calculation, you need the maximum concentration of antibiotic and minimum concentration of antibiotic. So these maximum concentration and minimum concentration of antibiotics will get it from the literature. And the Ke, either you can calculate the rate of elimination constant Ke by using the trapezoid rule, or you can get it from the literature also. And if you have these CSS and Cminimum, then you can happily can apply this logarithmic formula and rate of elimination constant. You can calculate the dosing interval. And this is for the D is the maintenance dose. And how if you have a maximum concentration, then if you know the volume of distribution of the particular drug, if you know that rate of elimination constant, Ke means the rate of elimination constant, then you can calculate the dose required for that particular patient. And if you know that CSS from the literature for that particular antibiotic like colistin, meropenem, if you know that volume of distribution of that particular antibiotic, just you can apply this CSS max into volume of distribution, then you got to know that loading dose. So you can give how much dose you want by applying this loading dose. And like you can apply the same formula for continuous infusion. If you want to give antibiotic the continuous infusion, so what is your loading dose? You can use the same formula. So like this is for the intravenous infusion, this is for that extravascular like oral route. So you have to use these formulas. You can calculate whatever you want. And one important thing is half-life of the drug and that elimination rate constant depend on these both are the dependent parameters, because these are values are like they'll depends on the clearance and volume of distribution of the drug. So if you see that as we discussed in the module 1, the clearance of the critical ill patient is very different from the regular healthy adult patient. The volume of distribution is very different in critical ill patient, very different from that healthy adult patient. So we know that clearance of antibiotic and volume of distribution of antibiotic will depends on the so many factors that will change in the definitely change in the critical ill patient. So if the clearance and volume of distribution will change for the antibiotic, automatically the TF and rate of elimination constant also changes. If you know the clearance of that particular antibiotic and volume of distribution in the critical patient, you can calculate the TF and rate of elimination constant by using the formulas. You can calculate the dose, whatever you want. See, for this case, for calculating the dosing interval, so you require the Cmax and Cminimum. So how to find these Cmax and Cminimum? Ways to find. Find these Cmax and Cminimum values from the population PK/PD studies. Those are already published in the literature that's similar to set of your patient. So this is called the therapeutic range. And so I choose, I'll go to the literature. I'll found desired maximum minimum steady state concentration for this patient is Cmax is C30 and the Cminimum is the 20 mg per liter this patient. So use this approach in case if the patient is never received any drug before. So this is the first time you are giving the drug, and so these two values you get it from the literature. And yeah, so this is for the step 1 to calculation of the dosing interval. So if you apply this dosing interval formula in this logarithmic formula, so what is the CSS max? 30 mg. Cminimum is the 25 mg. What is the rate of elimination constant? That is 0.139. This already we know. Just you can apply this formula. You got to know the dosing interval is the 1.3 days, but I can like make it as a 1 day. So your dosing interval is 1 day for this patient. I mean, you have to give the drug dose every day, means once a day. And how to calculate the dose? So if you apply this dose calculation, this formula, the maximum concentration is the 30 mg per liter, volume of distribution is the 50 liter, and your rate of elimination constant is 0.39, and your dosing interval is the T is 1. So if you apply this formula in this dose formula, like whatever we have here, this dose formula, this is the dose formula, automatically get able to calculate the dose, that is around 200 mg. So the dosing for this patient is 200 mg. The dosing interval is the once daily dosing. So this is the way to you can calculate dosing. This is the way to calculate the PKPD dosing. Yeah. See, this volume of distribution K is the differs from the same patient with a different clinical condition that I already told you. So the patient characteristics like such as weight, age, gender, renal, liver function, and other disease states and conditions that are known to affect the volume of distribution, elimination of the drug. And the second case, and the patient with an infection treatment with some certain of 5 antibiotics, calculate the loading dose and infusion rate. So there is one antibiotic called Y antibiotic. If you want to treat with an infection, so you have these population pharmacokinetic parameters for that particular antibiotic. Volume of distribution is the 50 liter, clearance is the 1 liter per minute, steady state is the 3 mg per liter. So for this infection, we are planning to give antibiotic as a continuous infusion. So for that, I need to use the continuous infusion PK equation, like the second one, this one. Don't use the IV bolus, because here I want to give as antibiotic as an infusion. That's why I want to use the continuous infusion equation. So you have to choose like whatever your dosing practices. If you want to give IV bolus, the dose, the calculations are different. Continuous calculation, continuous infusion formulas are different. Intermittent infusion formulas are different. So in the second case, I want to give as a continuous infusion. So my like calculation formulas are very different. So this is the formula for the dosing loading dose calculation. If I know already maximum steady state concentration for this particular antibiotic is 3 mg per liter, and volume of distribution is 50. If you can apply this formula for loading dose, your loading dose should be 150 mg. So this is the way to calculate the loading dose. If you know the steady state concentration, if you know the volume of distribution of the particular drug, so these two values, if you don't have it, no need to worry. You can find these two values from the literature with the same similar presentation like your patient. And how to calculate the infusion rate. If you apply this infusion rate formula, CSS into clearance, and what is your steady state concentration? 3 mg per liter. What is your clearance? 1 liter per minute. So your infusion rate should be 3 mg per minute. That means you have to give 150 mg of the drug with 3 mg per minute infusion rate. So there are some other equations I can use in my regular practice to calculate different dosing practices, like especially these table helpful in the research limited settings, where when you're practicing when you're giving your regular dosing, if you want to achieve some particular standard concentration or particular Cmax or CSS or C minimum, so by using these formulas, you can able to predict whether with your dose is help to achieve this particular concentration levels or not. Suppose if you give a like IV bolus drug, you know the dose of the particular drug, like either 100 mg or 500 mg, you know the volume of distribution, and you know the rate of elimination constant, and you know the infusion time. So just you can apply these parameters in this formula, and you got some value like 10 mg per liter or 20 mg per liter. So you already know your target is like 25 mg, but after applying this formula, you can achieve only 15 mg. That means your target is not achieved. That means you have to increase your dose. So this is the way where you can where you can calculate whether you can with your regular dosing practices, whether you can achieve the target levels of target concentrations or not. Here also you can use the different equations. This usually whenever we require, I am using this kind of equations in my practice. So this is also when you are calculating like different PK parameters. If you want to calculate rate of elimination constant, and you need at least 2 maximum minimum concentration of that antibiotic concentration you need. And TF formula is like 0.693 by KE. If you want to calculate the TF of the particular in that critical patient, you need rate of elimination constant. This rate of elimination constant, you can get it from the this first formula. And if you want to calculate the volume of distribution of the particular antibiotic, you can multiply dose by with the C0. Okay, and C0 is the concentration at time 0. And if you want to calculate clearance for that antibiotic, you can apply Ke into V formula. So this is the way you can calculate the whatever pharmacokinetic parameter you want. You can apply these simplest formulas. You can get whatever you want. And so how the Bayesian dosing software works. So initial dosing, initial recommended dose came from it came from that final PK model. Like I already told you, the population PKPD model. And we can consider the patient clinical covariates like renal dysfunction, weight, and pathogen specific information like MIC of the pharmacodynamic target. By using these targets, we make an initial recommended dose. And based on after giving the initial recommended dose, then we can measure the corresponding antimicrobial concentration. Then by using the individual PK model, then we can adjust the PKPD target whether we achieve or not. Then we can adjust the dose. This is the way Bayesian dosing software will works. And therapeutic drug monitoring. So basically, I think some of other speaker going to discuss about the therapeutic drug monitoring. Just I'm going to give the brief about the therapeutic drug monitoring. Identifying the relationship between the serum drug concentration and the intended antimicrobial effect. Limitation of the current clinical PD practices. TDM is the emerging alternative. So for especially antibiotic, this is the like optimizing antibiotic dosing tool is the controversial. We have a like supporting data and like we have a like non-supporting data for the TDM for antibiotics. In the view of MDR infections, TDM dosing prevent the toxicity as well as improve the clinical efficacy. It will prevent the so many studies. And when you consider the TDM, when you're treating the patient with infection, sepsis with augmented renal clearance, and severe trauma, burns injury, major surgery, febrile neutropenia, because this is the areas where you can expect that there is a lot of changes in the pharmacokinetics of the antibiotics. So that's why you cannot predict the proper antibiotic dosing. So that's why where the TDM has a greater role in these particular areas. And key takeaways: advancing the knowledge on the PKPD of antibiotic is very essential. One size fits all approach is unsuitable for the antibiotic dosing. So you cannot use same antibiotic dosing for every patient. Even IDS also in the AMSP guidelines, they have a grade 1 recommendation, grade A recommendation for the PKPD dosing. They said that you cannot utilize the same meropenem or same peptide dosing for every patient. You can change your dosing practices based on by using the PKPD dosing calculations. So this is the like one of the like mild moderate recommendation from the IDSA. So it's not always you can practice the standard dosing. You can change your dosing. It's not there is no harm in that. Like it's a like recommendation by the standard guidelines. So that's a like individualize the dosing. Local antibiotic data is worthful because it will always changing from from like epidemiology changes. So you cannot use one antibiotic in everywhere. And the TDM is another game changer, especially focus on the special patient population, what I told you. So these are my references. I think I conclude my session. And the true love shouldn't have you taking antibiotics. Any question and answers?
Thank you so much, sir, for adding your wonderful insights on PKPD of antimicrobials. The session was very informative. Sir, there was 2 questions. That is, the scenario is when a patient. Hello, am I audible, sir?
Oh, yeah.
Yeah. The scenario 1 is when we are dealing with urosepsis, and when empirical therapy started as an peptides or piperacillin tazobactam or ceftriaxone sulbactam. As PKPD suggests that these beta lactams will be having volume of distribution less than 0.6.
Yes.
When we are dealing with urosepsis, we need to deal both systemic infection followed by tissue, related to urinary tract. So the question is, will the penetration of this drug will reach enough in both?
Yeah, they'll reach. Especially carbapenems will reach. Until unless it is like a any cyst infection, we are using like polycystic kidney disease, we are using the quinolones. Other than that, if it is a regular pyelonephritis, beta-lactams able to reach the proper level. That is the reason we are giving the infusions to reach that at least minimum levels they can reach.
Okay. And the second one is related to when source of infection is MRSA. And as per the session now, the daptomycin is having more half-life and post-antibiotic effect than vancomycin. So what would be the optimal choice or optimal rational choice to go with?
So in vancomycin and daptomycin.
Yes, sir.
Either you can use anything. Generally, the reason is we don't use the vancomycin because of its toxicity. Okay. So the daptomycin we can prefer in the MDR gram positive infections, basically.
Okay. So these are all the questions, sir.
Yes, sir.
Thank you once again, sir.
Yeah.
And I just want to give a short brief again. The next module will be a basic module on therapeutic drug monitoring for antimicrobials by Dr. Ajmal, who is expertised in and he is an BCIDP certified person. And I just want to give a short brief of upcoming events of FCPI. First thing is CP Conclave that is held at Kochi, Kerala, organized by Amrita College of Pharmacy, collaborated with FCPI. And second one is CP Summit at Pune, organized by Infectious Pharmaceutical Indian Pharmaceutical Students Forum, and it is collaborated with FCPI. And the third one is the second ID Congress 2024, and the dates are 19 Jan 19 to 21. And the location is Calicut, and it is organized by ICRA Hospital under the collaboration of FCPI. So thank you so much for joining this session, and have a great day. Bye bye.
Reports on